Good afternoon, good evening, and in some cases, good morning. My name is Mark Monahan. I'm with Aquacast Liner, and I'd like to thank you for joining us for our featured webinar this month, Managing Early Onset Scoliosis with a Lateral Bending Waterproof Cast. Our featured speaker is Dr. Salil Upasani from Rady Children's Hospital in San Diego, California. The presentation will be followed by a question and answer period. So please send any questions you have in the Q&A section, and we'll do our best to get to as many as possible. Also, anyone who has registered for this will receive a copy of the presentation in email tomorrow morning, a link to that presentation. We've had a lot of interest in this webinar. Once again, we have attendees from 4 different continents, 13 different countries represented. And we've noticed that a large percentage of our attendees join within the first couple of minutes. So I'll give you the background of our speaker and allow these folks to sign on while we're talking. Dr. Upasani is a pediatric fellowship trained orthopedic surgeon and an associate professor of clinical orthopedic surgery at the University of California, San Diego, and Rady Children's Hospital, San Diego. He is the director of the International Center for Pediatric and Adolescent Hip Disorders and the program director of the Pediatric Orthopedics and Scoliosis Clinical Fellowship at Rady Children's Hospital, San Diego. Dr. Upasani graduated summa cum laude from UCLA with highest departmental honors in physiological sciences and a specialization in business administration. He subsequently attended medical school and completed his orthopedic surgery residency at the University of California, San Diego. During this time, he received funding from the National Institutes of Health to be the Ruth L. Kirchstein Research Fellow at Rady Children's Hospital, where he developed a passion for pediatric hip and spine conditions. Dr. Upasani is a highly sought after speaker, and we're really excited to have him join us this evening. And now I'll hand it over to you, Doctor.
Great. Thank you, Mark. And thank you for the opportunity to present on this topic. Why don't we go ahead and get started? So these are my disclosures. They're available on the AOS website. Nothing is relevant to the presentation this evening. This evening, I'll be talking about lateral bending casting. So it's a little bit different from the typical Edf casting that's used for early onset scoliosis, but I'll speak a little bit about both of those 2 different types. So the main condition that we're focusing on this evening is early onset scoliosis. The consensus is that it describes any type of spinal deformity with an onset at an age less than 10 years. And that includes a very large possibility of etiologies. So idiopathic, where there's an unclear or unknown diagnosis for why the scoliosis is forming. There's congenital or structural forms if there's failures of formation or segmentation of the vertebral elements. There's neuromuscular type that's associated with either increased or decreased tone of the muscles, or if it's coming from neurologic issues such as spinal muscular atrophy or spinal cord injuries. And then those with known associations with certain syndromes such as Marfan's, Ehlers-Danlos, and Prader-Willi. I'm just going to spend a few minutes talking about congenital scoliosis because it's a little bit unique, different from the other types. So this type of scoliosis is present in utero, and it's usually due to an abnormality in how the elements of the spine are formed. It tends to be more rigid and resistant to correction, and 50% of these deformities do progress rapidly early in childhood. The overall incidence of congenital scoliosis is thought to be, between 0.5 to 1 per 1,000 live births, and most occur spontaneously, and there is a risk for future siblings of parents with children involved with congenital scoliosis having multiple vertebral anomalies. The thought is that this forms during gestation at about 4 to 6 weeks, so it's important to consider the other organ systems that are developing at that same period. And there's been some connections with maternal or fetal exposures to such things as alcohol, valproic acid, or even hyperthermia. And kind of the evolving theory is that hypoxia is related in some of these abnormalities. And there have been identification of this HES7 gene thought to have a haploinsufficiency of the Notch signaling pathway, leading to abnormalities in how the vertebral bodies are forming. So we all know to look for associated anomalies because 60% of these patients have other issues such as heart problems, Klippel file, or problems with how the kidneys or bladder is formed. And these are typically diagnosed early in childhood. So these deformities are thought to progress based on 3 factors: where the anomalies in the spine are, what type of anomaly the child has, and how much growth is remaining. So there's rapid period of growth in the first 2 years of age. And then again, the peak height velocity, which occurs during adolescence, slightly different between boys and girls. So the different types of anomalies that are present, this figure kind of shows the various abnormalities: block vertebra, which is shown on the very left of the figure; wedged vertebra, where there's still pedicles on both sides of the vertebral body, but it's a wedge deformity; hemivertebra, which are all failures of how the vertebral bodies are forming; and then the bars that can be present with failures of how the vertebral bodies have segmented. And a lot of natural history studies, especially by McMaster, have gone through the risk for which of these deformities progress and which need either surgical treatment or further treatment into childhood. And if you look at his the publication that was referenced there, he kind of breaks down the different types of congenital anomalies as well as where in the spine they occur, with an average amount of deformity progression per year. And you can see on the far right in that bold box, those deformities are the ones that have the highest risk of progression and needing treatment from an orthopedic surgeon. So for the types of scoliosis that are not congenital, so that don't develop in utero, the risks for progression are shown here. So really dependent on the underlying diagnosis. So if it's due to a neurologic abnormality or syndromic condition, also you want to look at the ambulatory potential of the child. And then these 2 radiographic findings have been described and are kind of the most commonly used to assess for risk of deformity progression. So the top image shows the rib vertebral angle difference, which is measured at the apical vertebra, where you're looking at the relationship between the vertebral body and the convex and concave ribs. So that's been shown to have high intra and inter observer reliability, and a rib vertebral angle difference of less than 20 has been shown by the study from Mehta to have resolution of the spinal deformity in 83% versus RVADs greater than 20 have a high risk for progression. And then we're also looking at the rib phase, which is shown in the lower image there, which assesses the amount of overlap between the rib head and the apical vertebral body. Again, phase 2 ribs are at a higher risk for deformity progression. So those are the kids that you're following more closely, and you're going to talk to them about interventions to minimize deformity progression. So regardless of the type of early onset scoliosis that the patient has, the goals of treatment are to limit deformity progression, maximize the potential for growth in primarily pulmonary function for these children, and then maintaining a balanced trunk and spine throughout growth. And so this is my treatment algorithm. Usually it's close observation for patients with curves less than 30 degrees and a rib vertebral angle less than 20. The patients that we consider bracing is usually the idiopathic infantile scoliosis or syndromic curves. And the previous literature showed bracing to not be as effective as casting, but the newer studies show it to be a little bit more promising. And then casting, these are the 2 main types that we're going to be talking about: EDF or lateral bending. The primary indications for casting are when the spinal deformity increases in magnitude more than 30 degrees, If you have that large rib vertebral angle difference, if you have a rib phase of 2, or if you have documented progression of the curve, and obviously all of these patients are extremely skeletally immature, so there's risk for the curve to continue to progress. And then surgical intervention is usually reserved for patients that continue to progress despite casting or bracing. And obviously there's tons of information out there about growth preserving surgeries. But this talk is really going to focus on the casting aspects of it. So when we're looking at casting for early onset scoliosis, I think there's a good consensus that we want to start as early as possible. So this study by Mehta from 2005 looked at 136 children prospectively. She kind of broke the kids up into 2 groups. The first group was 94 patients that were referred early to her clinics with a mean age of 1 year, 7 months, and the Cobb angles shown there. Scoliosis resolved by a mean of 3 years, 6 months in these patients, and all of them, or most of them, did not require further treatment. And in her group 2, or 42 patients that presented later to her clinic or were referred at a later period, casting reduced their spinal deformity, but it did not reverse it. And at least a third of them needed spinal fusion. And her conclusion in the paper was that most of those kids in the second group would require further treatment or even surgery. And multiple studies have kind of reinforced these results, encouraging us to begin casting at less than 24 months, obviously, if possible, if the patients present to you that early. So let's spend a few minutes talking about EDF casting. It's elongation, derotation, flexion. So we don't really do this type of casting at Rady. So I called on my friend Michelle Wellborn from the Shriners Hospital in Portland, and she shared some slides with me. Primarily, we're looking at stretching the spine, so applying a longitudinal force, which is usually provided by this pelvic girdle, and then traction underneath the jaw. The weight of that traction is usually about 40 to 50% of total body weight. And as this cast is applied, there's a lot of derotational forces, as shown in the figure in the bottom corner there, to allow us to derotate the spine and improve the alignment in all 3 planes. And then there's defects that are cut out of the cast to allow the ribs to rotate into the cast voids while applying pressure to continue to derotate the spine straight. So this is a quick example from Michelle showing a 12-month-old female who presented to her clinic with a 55-degree curve, otherwise healthy with a normal MRI. So by process of elimination, this child would be thought to have an infantile idiopathic scoliosis. They underwent 5 casts. So the casts initially were every 4 weeks, and then she spread that out to every 8 weeks. And she continues to cast the children until there's no clinical evidence of scoliosis. And then they're transitioned to a brace, a full-time brace for a year, followed by nights and naps for a year. And you can see the progression or the improvement of their scoliosis over that time period. So as Mehta's study showed, for these patients with infantile idiopathic scoliosis that are diagnosed early, casting is really successful in even curing the scoliosis or completely correcting the deformity. So the remainder of this talk is going to focus more on the technique that we use at Rady Children's Hospital. It's this lateral bending cast. It was originally described by Bradford and Brackett back in 1893. And then there's some kind of misrepresentations of Risser casting that go along with it. It was originally described for adolescent scoliosis, obviously mostly applied in teenage girls before spinal instrumentation improved significantly. It's gone by the wayside for adolescent scoliosis, but I think it's still a good viable option for delaying curve progression in children with early onset scoliosis. So you'll see some differences from the EDF cast, especially in this clinical example where we show how this cast is applied. So this is an 8-year-old male. He has a CBL mutation associated with a Noonan-like syndrome. So he would have the diagnosis of syndromic scoliosis, and again, early onset because he's less than 8 years of age. He also has autism and has a lot of sensory issues, which definitely plays a role when you're going to place this child into a cast. You can see on these x-rays he's wearing earphones, so he definitely has hypersensitivity to sound. He has this pretty significant left-sided curve and a normal MRI. So this was his curve magnitude when he presented to my clinic, 82 degrees left thoracic curve. And again, I mean, we can touch base on indications for who to get an MRI, but basically any child that presents with the scoliosis at less than 10 years of age that's progressed significantly would be an indication to get an MRI. So the lateral bending casts are applied in this fashion. So the child is placed under general anesthesia. We're using some blankets to cover for PHI reasons, but this is his head on the right side, his feet on the left side. Again, if you remember, he has a left thoracic curve. So the apex of where this force is applied is right at the apex. So I'm going to go back here. So if you can imagine that muslin is placed right at the apex of the deformity to place that lateral bending corrective force. So the muslin is coated with some tape, and lube is placed around the patient's torso right at the apex of the deformity. And then we're using his body weight to hang the patient to apply that fulcrum bend to his spine. And then this kind of gives a view from above. You can see that we're using the aquacast material around his skin. We place this blue tape, which is used to protect the patient as the cast is being removed. It's being split on both sides directly over the tape. And then this is where the void will be to allow his spine to derotate into once we trim off the remainder portions of the cast. Again, you can see his arms up here flex at 90 degrees, and then you can see a good mold at the top of his pelvic brim to get a good fixation of his pelvis. So this is him after the muslin has been cut. He's brought supine again. And we're marking out the areas that are going to be cut out with the cast. This void up here to allow for that arm to settle down. And then again, for the ribs to rotate into this open spot. So you want to make sure you have a large belly hole for breathing as well as expansion when the child is eating. And then there's also cuts made over here to make sure that the hips are able to flex at least 90 degrees to allow the child to sit. We get an x-ray on the table once the cast is placed and the cuts are made, and you can see a significant correction of his 81-degree curve from preoperative. And so typically we see the patient back in clinic. So these kids are always admitted for an overnight stay for their initial cast, primarily for pulmonary reasons. We want to make sure that they're not having any difficulty with breathing, and that the cast is fitting properly. They're usually discharged the morning after the procedure, and then they follow up in clinic that week or the following week to make sure that they're tolerating the cast appropriately. So here you can see that we're using high tape to protect all the cut edges of the cast. And this is him again with his headphones on, but tolerating the cast very nicely, allowing for good mobility, and allowing for his mother to shower him, once or twice a week to allow them to clean off his skin. So again, this is him in his initial cast, starting with an 81-degree curve, improving to 39 degrees. We'll plan to keep this cast for 4 months and then transition him, give him a holiday for a week to allow his skin to breathe, and then go back into the second cast to continue work to improve the magnitude of the curve. This is a second example that I wanted to share. So he presented at 11 months of age. He primarily had a skull and chest wall deformity, and the pediatrician was worried about a scoliosis. At 11 months, he had a pretty significant curve at 60 degrees. He underwent a complete genetic workup, which was negative for any abnormalities, and had an MRI, which was within normal limits with a otherwise normal physical exam. So this child was thought to have infantile idiopathic scoliosis, and he underwent a series of casts. So this is his first cast. You can see significant correction down to 12 and 13 degree upper thoracic curve. which was maintained for 12 weeks, had a second cast. This is him in his third cast. And then this is him at 4.5 years of age. You can see still a small residual curve there of 24 degrees, but we're bracing him currently. And this is his most recent x-ray out of brace. So the goal obviously is to continue with this process for as long as possible. If we start to see that there's a recurrence of the curve or it's starting to increase again, we would recommend that he goes back into casting and delay the need for surgical intervention for as long as possible. So there's definitely some complications to be aware of and be prepared for with early onset scoliosis. So there's the cumulative exposure of anesthesia. There was a study by Larson that showed that the mean anesthesia exposure was 122 minutes per cast for that EDF technique. And according to the FDA recommendations, they recommend less than 3 hours before age 3. I think the lateral bending technique is quite a bit faster than the 2 hours that's reported, at least in that study. At our institution, it ends up being about 60 minutes total for the patient to get the cast and be trimmed and get the x-ray before they're extubated. Rashes and bruising, it's basically ubiquitous. Every patient is going to get it. It rarely delays the next cast. Usually a 1-week cast holiday allows those skin issues to resolve. It's pretty rare where we get an actual ulcer that would require us to remove the cast early and allow the skin to heal before applying the next bending cast. Again, rib deformities are pretty common. They especially occur in floating ribs. DVT is a very rare complication that has been reported. And I think especially if the upper portions of the cast cause some tight pressure around the axilla, that is a risk factor for a DVT. Brachial plexus palsies, again, are extremely rare. And then cast intolerance, I found it to be extremely low with these aqua casts where the patients are able to bathe if they get their cast dirty or if it's soiled for any reasons. And then it's obviously important to be aware that this could impact activities of daily living and acquiring milestones. But again, we talk to the parents about the risks and benefits, and especially the benefit of avoiding surgery at a young age, which has been shown to have 100, 200% risk of complications. So as a summary, I started using the AquaCast material back in 2013 when I started my practice. I found it to be extremely effective for limiting early onset deformity progression. It seems to be very well tolerated by patients and their families. Again, it allows us to shower, run water through the cast. Found fewer trips to the OR to change out the cast for it getting soiled or any skin-related issues with the casting. And I think it's able to maintain the 3-point mold, at least with this lateral bending technique that we use. It'd be interesting if anyone in the audience uses this material for EDF casts or any experience that they have with maintaining the mold with it. So some quick take-home points. The casting for early onset can cure 20 to 30% of infantile idiopathic scoliosis, especially if started under the age of 2. We use it primarily to delay surgical intervention. AquaCast is well tolerated and can maintain the mold, especially in these lateral bending casts. But it's important to monitor your patients closely and make sure that you stay on top of the curves if you notice some recurrence, and to be conscious of the radiation exposure for these children. So we're getting a lot of x-rays throughout their lifetime. So while the patients are in the cast, and especially when they come out of the cast for that first visit, I'm basing my assessment primarily on a clinical examination and assessment of their rotation and trying to minimize the amount of x-rays that they're getting. And obviously extremely important to follow these patients until skeletal maturity, because all of these different diagnoses of early onset scoliosis can be problematic and cause progressive spinal deformities. Thank you very much. So those are my prepared slides. I'd be happy to take any questions that you guys might have.
No, that's terrific, Dr. Upasani. Thank you so much. Great job and great information. Just a reminder to everybody, this presentation will be sent to you automatically tomorrow morning, I believe. And we definitely have a number of questions that are coming up, and we'll kind of get into them. But if you think this is something that you would like to integrate into your practice, Aquacast is doing clinical trials and get you started pretty quickly. So if you're interested, just shoot me your name in the chat, and we'll get right back to you. But so Dr. Upasani, back to some of the questions. There are a lot around what I guess is you refer to as ADLs, activities of daily living. Some around just, what can you do? What can't you do? But what are there any limits to what you allow your patients who are in these casts to do or not do?
Yeah, so while the kids are in the cast, they're obviously limited in terms of their trunk flexibility, trunk mobility. I do encourage them to be as active as possible, but obviously the cast is limiting them, especially in participation in sports or, most of these kids are younger than the 8-year-old that I showed. So they're not really playing a bunch of sports. But I encourage them to walk, they encourage the parents to take them out, put them in their car seats. And, we want to make sure that they're sitting appropriately with their hips flexed to 90 degrees. So there's no limitations in that way. But basically the main limitation is with sports.
Sure. That makes sense. And then are you applying the cast yourself, or are you working with an orthotechs or a team of other surgeons?
Yeah, we have an orthotech with us. So we have a fantastic team at Radies of almost 10 orthotechs. So there are 2 or 3 that are more comfortable with this type of casting. So they're usually the ones in the operating room with us. I'm obviously there for every cast that I apply. And sure. I think after the material is placed, there is a lot of corrective maneuvers that you can do, especially making sure you get a good mold above the iliac crest. You can apply a derotation through this technique as well, basically untwisting the spine and then correcting the sagittal plane. I forgot to mention that for that case example that I showed, but he had a significant amount of kyphosis as well, which we could flatten out in the cast along with his coronal plane deformity.
Okay. And now, are you using extra padding on the apex of the curve under the cast to prevent?
Yes,
okay.
Exactly. Yeah. So extra padding at the apex, extra padding at the iliac apophysis, and then extra padding underneath that armpit, where you expect kind of the 3 points of that mold to be applied during the correction.
Okay. And then you mentioned a cast holiday. That's one of the questions that came in patients that are struggling to adapt to life in a cast. Is it okay to take a cast holiday and temporarily put them in a brace? What are your thoughts around that?
Yeah, absolutely. I mean, you need the parents to be on your team, and
sure.
If the child is old enough, obviously, to get them engaged and part of this care plan. So I'm always happy to give a cast holiday. The parents see how difficult it is to maintain a brace in very young kids. They're very resistant to putting it on. They're very fussy when it's on. They try to take it off quite often. So I think, and giving them the data in terms of the previous studies have shown that bracing is not well tolerated in these patients. And a lot of them come around to the fact that, yeah, it's actually easier to put a cast on and there's no going back. You can't take it off. The parents can't take it off. So the child is going to be in the cast, and there's no other options.
No. And would you be able to like clamshell the cast to kind of open it up? Is that how you would go about it?
Rarely. I've especially for that top portion, you could bivalve a little bit anteriorly to open it up, especially if they're feeling a little bit too much pressure under the apex, to buy, a little bit of time until the next period when you're going to remove the cast. But that's not often. We don't often have to take or modify the cast once it's applied.
No, because you had mentioned, I think the one time it was 4 months for some of these.
Yeah. We shoot for 4 months. So again, decreasing the number of times that we have to go back to the operating room. You saw with that case example from Shriners Portland that it was changed quite frequently, and I think that's kind of the experience with cotton casts. They do get stinky, get dirty. You can't get them wet. So you do need to change them out a little bit more often, I believe.
And what would you say the percentages of EDF versus the LBC casts? Yeah, any idea?
I'd say the vast majority is probably EDF casting. During my
Okay.
fellowship in Boston, we were definitely doing EDF. I worked a bunch with Mike Glotzbecker out there, and he was using the waterproof material for the EDF casting too. So it'd be interesting to get his experience with it as well.
Okay, and then one specifically, it's around an article that was published in the 2013 Journal of Pediatric Orthopedics. It says it discussed the pitfalls of increased peak inspiratory pressure, PIP, and infantile scoliosis casting. What measures have you taken in the OR to create better outcomes where this is a concern?
Yeah, no, so definitely the patients are under general anesthesia. The pressures for their respiratory function are measured. It definitely decreases or increases significantly as we're applying the cast. As we're cutting out the voids and the lungs are able to expand, those pressures normalize before the patient is extubated. So that's very closely monitored during the procedure. So I think it is important to apply these under general anesthesia in a very controlled environment. We're not doing it in clinic with the children awake. And that's also the primary reason why I keep them in the hospital overnight for that first cast, because there's always some surprises that can come up. And often, I'm trying to think back if I've ever had to remove the cast during that hospital stay, and that's not the case. Like worst case scenario, we've bivalved it, but we've never had to remove it or reapply it. And then the second, third casts that go on, parents are very comfortable with the cast, obviously, and they know exactly, so when the patient goes to the recovery room and the cast is being pedaled by either the nurses or the orthotechs, the parents are very kind of particular of the different areas how they want the cast customized to make sure that they're not going to have any issues. So they become experts with it, right after the first cast.
And this is kind of in line with the respiratory concerns, but what is your recommended time to schedule the first follow-up appointment with the patient?
Yeah, I think so. Within the first few days, or at least within a week, is really important. So these are the types of patients that should have either your phone number or your nurse's phone number to be able to get in touch with you within the first few days. And then it's great to see the patient once they're upright to see how the cast is still fitting on them, and if the children are having any problems with breathing or eating, all the things should be monitored within the first week.
Okay. And then this is kind of a two-part question, specifically around the application. It says how many layers of the padding are generally used? And then would you all have any video available of this technique?
Yeah, that's a great question. So I need to shoot a video, and I will get that out there. I think it is important to be able to document the exact application technique. So in terms of layers, it would be at least 3 layers, and especially at the apical regions, 4 to 5 layers. So not necessarily always going all the way around. There's often times when we just cut out little 10-inch straps. Yeah. To put a little extra padding, especially at the areas where we're going to be applying the most amount of pressure. But I'm definitely going to get a video prepared.
No, terrific. Yeah. Well, I'll tell you on behalf of Dr. Upasani and the AquaCast team, thank you very much for joining us, everyone. And Dr. Upasani, thank you so much for taking time out of what I know is a very busy schedule. So we appreciate that. And if anyone would like any more information about AquaCast, you can visit our website, www.aquacast.com. And once again, final reminder, this will be heading out to you tomorrow. For those who obviously couldn't join us, it'll be going out to everybody who signed up. But Dr. Upasani, thanks so much again for your time. And everybody have a great afternoon, evening, and morning. Take care.
Thank you. Take care.
Bye-bye.